What's the easiest way to do a skin biopsy in the office? I frequently talk to doctors and they say, really, I don't have any time in my practice to do biopsies. It's too kind of complex. Um, I think the reason we don't do things in our office is because they're complex, and there is no easy system. I'm a real big systems person. I think systems make things a lot easier, and I want to explain a little bit of my workflow for biopsies. I'm doing this in first couple of reasons. One is because I'm going to be doing a lecture at a upcoming APMA meeting, or not APMA, but one of our like mass APMA meetings about biopsies, and I just hear that someone said our rep anyway who looks at my biopsies, I do a lot more than others, and I don't feel like I do a lot more. And I had one of the doctors in our office actually sent me a patient to do a biopsy on today, and I'm like, this seems so easy. So let me talk you through what I do. So first of all would be like the room prep. So all of my rooms on the bottom drawer, they have like specimen bags, and they have those little formaldehyde filled little containers. I don't know if it's saline or formaldehyde. I think it's formaldehyde little containers, and then they have 2 millimeter punch biopsies. So that's really it. 99% of the time, that's what I'm using. And my process, so for example, there was a patient that came in today that needed a biopsy, and one of my colleagues sent them over for a biopsy. But even if they didn't, so the process is like if I see someone needs a biopsy, I have a little button in my room, so I click the button or I open the door, and that triggers my staff. They come in, I say I'm going to do a biopsy, and then what that triggers to my staff is that I need 1 cc of Lido with epi, and I need a consent for a biopsy, and that's about it. And they do them where they do the lidocaine first, and then they do the consent second. The reason they do that is so I can do the lidocaine, have it numbed up, and then they come and get consent, and then I can do it. I do it all when I'm sitting there. So literally it takes like 30 seconds to numb them, because I just do a little wheel underneath the lesion. And then I take that 2 millimeter punch. I do one punch, and I'll take a little tissue nipper, cut that out. Second punch, pull it out, put some gauze and a Band-Aid, and I'm done. And then my staff, if they haven't got consent, they'll come in and get consent. So it's really the most concise way to do biopsies that I know of, and it literally takes me like 10 seconds to say that to my staff, 10 seconds to numb them, and maybe 10 seconds to do the biopsy. So it really doesn't take that long. It doesn't really add anything. They don't have to come back. The only ones I would have them come back for would be like nail matrix biopsies. Those can be a little bit more time consuming, and I like to plan those. And also nail sample biopsies are really easy. I just take a little clipping of the distal nail. I don't call that a nail biopsy. I just call it like a nail pathology sample. When I do an actual biopsy, it's usually for like a melanonychia or something that I'm concerned of in the toenail. So that's how I do it. I'd love to know what other people do or why you're not doing it. It's pretty easy to do as long as the staff knows what's going on. Okay, so let's go into this day. This is a recording from a Tuesday in the office. First patient, 63-year-old man, right plantar fasciitis. He's 50% better. I don't need to see him back because he is feeling better. He's 50, probably a little bit more. Next was a 62-year-old female, had right cariflex. She actually came in from a referral from one of my colleagues wanting cariflex, but actually I think she benefited from Onifix better. So cariflex, by the way, is that fake toenail you put on that makes it look good. Onifix is for ingrown toenails. Now I'm using this a little bit off-label. I find with some patients with onycholytic nails, I trim back the nail and I apply it at the base. So I find that a lot of times nails get thicker because there's micro movement. So when they're onycholytic or detached, they move more, and then they get thicker to kind of mitigate that extra movement and to make it more stable. So I think by putting the Onifix, which is like this little resin that I put on the nail that it's like a speed bump, and I put that on there, and then it kind of stabilizes it as if it was a multiple layered nail. That stabilizes it as it grows out. Sometimes it can help it to reattach. But this is actually one of the more challenging things that I treat, getting nails to reattach, and I'm not that good at it. But that sometimes works for some of my patients. Okay. Next patient was a 49-year-old man. He had left plantar fasciitis with equinus. He got my Pelto Special, which is the night splint foam rolling and morning stretch, and he also got meloxicam. and I'm going to see him back in 4 weeks for an ultrasound and possible shockwave. Next was a 56-year-old female for bilateral foot pain. This is kind of a challenging one. She has these weird pains, and she requested PT today and requested disability. And I don't do a lot of disability, like short-term disability, but she had to come back again today, requested that, and I gave her PT. So I'm going to see her back after 2 months. Next was a 59-year-old female for left foot fracture. She has pain that continues, so I ordered an MRI after having her in a cam boot. So I'm going to see her back after the MRI. Next was a 62-year-old male for a diabetic foot exam. I did that. That was there tends to be lower level 3 visits, and I'm going to see him back in 1 year. Next was a 60-year-old female for right second med head pain. She got meloxicam, and if it's not better at the next visit, so possible like capsulitis, I'm going to see her back. She's going to do contrast baths, meloxicam, and different shoes. I'm going to see her back if it's hurting, continues to hurt. I'm going to get an ultrasound, but I did not make a follow-up for her. Next was a 77-year-old man, had a right lateral hallux avulsion, and he also wanted nail care, and I'm not going to. Actually, he wanted to be back for 3 months for nail care, so I'm going to be him back in my nail care time Friday mornings. Next was a 53-year-old man for a left lateral foot biopsy. That's the one I just talked about, or for one of my colleagues here. Next was a 80-year-old female for. This was kind of this was a good patient. So she had right midfoot arthritis. I got X-ray. I got ultrasound. I did a ultrasound-guided cortisone injection to 2 of her joints, the second MC joint and the navicular cuneiform joint. And then I talked to her about gapped lacing, and I scanned her for orthotics. And I talked to her potentially in the future to do shockwave for the bone marrow edema. Once again, it doesn't help with the arthritis, but sometimes can help mitigate the symptoms if the orthotics aren't sufficient. I'm going to see her back in 2 months. So that was a good patient because of the orthotics. Next patient was an MRI, 68-year-old female MRI follow-up for plantar fasciitis. She had a lot of things in her MRI. I reviewed that. Now, one little tip, this is what I tend to do. I tend to review X-rays before I see the patient. I review MRIs before I see the patient, and I don't always show them the X-rays or the MRIs. Sometimes I do, but a lot of times the patients don't know what I'm looking at, and they don't understand, and they get confused. And they'll ask me what those 2 little dots are underneath the big toe, the sesamoids. And so, but for this one, I did go over the report a little bit, and I gave her as well a couple of injections because of the midfoot arthritis she had. She also had a midfoot arthritic joint, and I did 2 cortisones. And due to the pain and the arthritis, I put her in a cam boot. So I did some DME for her. I'm going to see her in 1 month. Next was a 53-year-old man for left hallux limitus. I talked to him mostly about shoe gear because I think it was more of a shoe issue that was irritating him. I'm not going to see him back. Got X-rays and things like that. Next was this was an MVP patient. So let me tell you about this. This was a Medicare patient that has Mass Health. So these ones, Medicare pays 80%, Mass Health, the patient opts to pay for 20% because we don't take Mass Health, which is like Medicaid. Bilateral foot pain, bilateral plantar fasciitis, bilateral equinus. So they got foam rolling, night splints bilaterally, and then a morning stretch. And this patient, we talked about doing either cortisone or shockwave if they're not better in about 4 weeks. So it was good because of the bilateral night splints. Now, I frequently do, if they have bilateral symptoms, I'll do bilateral night splints. In the past, what I used to do is I say, okay, wear it one night one side, one night the other side. But I have no issues with insurance covering 2 of them, so I tend to get them too. Next patient was a 46-year-old with bilateral Achilles tendonitis. So I did bilateral shockwave, number 3 out of 6. She was really kind of concerned, so I had to spend a lot of time just calming her down. I think insertional Achilles tendonitis is one of the more challenging things I treat with shockwave, but she tolerated it well, and she is seeing some progress. Next was a 40-year-old man for a right matrixectomy on the lateral side, and he also did the kit. So one thing I've learned for a couple of things. I can depend on my staff, and I think they do a good job at explaining like why they need an even up with every single walking boot. Like the even up is that thing that you strap on the shoe, so that adds an additional $30. Or why they need the Amerigel kit every time I do a matrixectomy, that adds another like $60. So, but I find that if I present it to the patients and then hand it off to the staff just to fulfill it, it works a lot better than them coming in and having to explain it. I find a lot of times the staff have a challenge with doing that. So I find it helps them if I prepare this patient for that. Next was a 69-year-old man. He had 4 Swift treatments, and here he's back for his 3-month follow-up, and he is feeling much better. And so I got a box of tips out of that one because I did a YouTube short for that patient. So just so you know, if you do Swift and you do short videos and you send it to them, they will give you I think a box of tips, or one tip, or I don't know how much tips, but that's what they'll do. Next was an 18-year-old man that had Down syndrome. So he had bilateral pes planus, posterior tibial tendon dysfunction, athlete's foot, and nail fungus. So he got, I sent him to Hanger because, once again, he has Medicaid and, Blue Cross, and I can't do AFO. So he's going to get bilateral Ritchie braces from Hanger. Unfortunately, I couldn't do those. And then he's going to get the Pelto special for fungus, which is he's going to get terbinafine, and he's going to get LFTs, he's going to get the UV light and shoe spray, and the biotin. Okay. Next patient was a 75-year-old female for right ankle sprain follow-up. Her sprain was feeling better. She had an ATFL issue, and now she had some pain in the sinus tarsi, so I did a cortisone injection in the sinus tarsi, and this was all after her PT. She's going to transition down from the ankle brace into more of like a neoprene base, and then she'll follow up as needed. She originally had an ankle brace dispensed. A 39-year-old female next for wart that had cantharidin. She's on number 4, I think, of this cantharidin treatment. Next was a 41-year-old female for left second met fracture. This was another MVP because she had a second met fracture. I gave her meloxicam like I do for most patients. I dispensed a cam boot, and I used fracture care for this patient. So fracture care, yes, there's a 90-day global, but I'm going to see her back in 4 weeks, and hopefully that'll be it for the follow-up. Next was a 48-year-old man for right shockwave number 4 out of 6. He has, on the MRI, he had some bone marrow edema around the subtalar joint region, and I did focused shockwave there, and then the radial shockwave on the peroneals. And then the last patient of the day was a 61-year-old man. This is a challenging one. He got new orthotics. He had done well with his old orthotics for 9 years and developed plantar fasciitis again. And I got him the orthotics. I did bilateral cortisone injections because he's a butcher and he owns his own butcher shop, so he can't take time off of work. He didn't have much improvement with the cortisone injections, and I was a little paranoid because when I saw him, he wasn't getting better, and I always get a little concerned when they get new orthotics, and I was like, man, I use the same company, and so usually I use Forward Motion, but in this case he previously had Northwest, so I ordered Northwest orthotics just to make them just like the other ones, and then it kind of dawned upon me, and this is a kind of mistake I made a lot in the past, so I want to share this with everyone. Patients, if they get orthotics too soon, when they have plantar fasciitis, the orthotics don't feel good. And I know this is kind of obvious. That's why when I see a patient for plantar fasciitis, I don't tend to scan them the first visit. I do it when I'm doing shockwave. I'll do it the 3rd visit because hopefully by the time they come in at the 6th week where they get in the 6th shockwave, they're actually already starting to feel better. Because if you have plantar fasciitis, nothing is going to feel good. Like no orthotic, in my opinion, is going to really feel good. It doesn't do a great job at taking down the pain. It does a really good job at kind of offloading the fascia to help it prevent it from coming back. So for him, I said, hey, you're gonna, I would, it's 9 years after you had it before. He had thickening of the fascia. I gave him options of doing cortisone injections. This would be cortisone number 2 on bilateral heels, or you could do shockwave. And I said, with the thickness of the fascia, I really think shockwave would be the best. And so this is kind of a challenge, I think, for some people, and for me actually too, but let me explain how I do it. So bilateral shockwave for 6 sessions ends up for me to be about $3,000, and that can be a big value, a big amount. And for him, I basically said, I know it's hard for you to get here because of time, so I was willing to see him first patient so we could open up his store, or even a little bit before, first patient at 8 a.m. for those 6 visits. And then I also said, for the 6 sessions, it's bilaterally, so usually for one side it's $250, so 2 sides is $500 per session, so that's $3,000. And he was aware, and how I kind of explained, I said, the $3,000 isn't usually the problem. The problem is getting your butt here 6 times, and that's really true. I think for people that have a good job and that have their own business, it's not the $3,000, because there is, I always say, the 82 to 85% success rate. It speeds up the healing by 50%. That's how I explain Shockwave. It's more getting there 6 times. So I try to make it as easy as possible for him to get into the office. Okay, so that was the day. Once again, hope you guys found this beneficial. I am putting together a challenge, a 6-month challenge for a group of doctors, a kind of a select group that want to help get their practice to the $1 million mark. I want to be clear, this is going to be more for doctors, as I've been thinking about this, more for ones that are probably in the 600 or 700 realm, wanting to get to the $1 million mark. That's a little bit easier, because if you're under that amount, you're probably not busy enough. And then if you're not busy enough, you might have a hard time paying for it, but also you just need to work more on marketing. As I've mentioned before, there is this isn't my idea. I'm stealing this from Alex Hormozi, but there's either a supply issue or a demand issue, and it's a lot easier to deal with a demand problem. With a supply problem than a demand. So demand problem meaning there is not enough demand, and you have to really just. If there's a demand problem in your practice and you're not busy enough and you have open slots, you have to do everything you can to fill those up, and that you have to learn. So my favorite book for that is going to be $1 Million Offers and $1 Million Leads. Okay, so $1 Million Leads will help you to kind of fill that up. I do have information also on my Practice Mastery Academy about all of that. But then once you have the demand filled and all your slots are filled, then you have a supply problem, meaning you don't have enough supply. You have too much demand and not enough supply. And then what you do is you optimize. So that's where you have to do all these other things to make your practice more profitable. And that's where I think my sweet spot is helping you get your time back and doing it more profitably. So that's what we're going to talk about in this challenge. So if you're interested, go to podiatrypracticemastery.com/challenge, or you can shoot me an email. I'd love to share more about it. Okay, Don at podiatrypracticemastery.com. Thanks. See you tomorrow.